without further ado, our new friend and hopefully, a continuation for the future, Dr. Paul Kuo is waiting. Dr. Paul will be talking about management of the post-liver transplant patient. He's currently the professor of medicine and director of hepatology at Stanford, holds over a 2-decade experience in managing liver transplantation. And he's recently authored an article on the ACG clinical guidelines in the evaluation of abnormal liver tests. It's very important that we don't use the shotgun approach in diagnostics. Everything has to be justified with solid clinical reasoning. And as far as liver transplantation goes, if we just take the government sector in Pakistan, we are doing about 8 to 9 liver transplants every week in the main 2 centers, Gambat and PKLI. And if we add the private sector to it, the number goes over a dozen a week. Of course, it doesn't compare to many top-end centers in either the Far East or the West, but it shows that the pool that you will be dealing with is increasing day by day. And Dr. Paul Kuo will be talking on that. Sir.
Thank you very much. And good afternoon. I am going to spend the next 20 minutes walking through some practical points on managing post-liver transplant patients. There we go. No disclosure. So who's getting transplanted? So this is a snapshot from the U.S. and Europe. Looks very similar to this. It's different here where you have such large viral hepatitis populations, but hopefully with DAA therapy, you will be able to reduce the number of hepatitis patients over time who present and require transplantation. But for us, it is mainly metabolic liver disease and alcohol-associated liver disease. However, there was this very interesting paper that came out maybe 5 years ago. And I think this probably also is reflected here as well, which is that even though in the U.S. it's metabolic disease, alcohol, followed by viral hepatitis, if you look at hepatocellular carcinoma, regardless of what the underlying liver disease is it turns out that's the leading and most common indication for liver transplant. And here, what I've been impressed upon is that you have here just so many presentations with hepatocellular carcinoma, and my belief is that you too have a substantial HCC population that requires liver transplantation. So that's something to keep in mind as we move forward. We also now are changing in our view about disease recurrence. So as was so kindly noted, I actually spent 20 years of my life treating and addressing post-transplant hepatitis C, which is now a disease that can be treated in 8 to 12 weeks. As I like to say, my 20 years of my life went into a single Excel table, which is okay. It just shows you how highly effective direct-acting antiviral agents are. But hepatitis C was 100% recurrence. Hepatitis B was problematic for a period of time. And of course, our immune diseases, non-alcoholic fatty liver disease, and other diseases would recur. And of course, we also have to survey for liver cancer in those that we transplanted for HCC. Nowadays, we know that hepatitis C can be treated essentially 100% of the time, and our hepatitis B recurrences are low. When we now need to look at metabolic disturbances, particularly for those we transplant with non-alcoholic fatty liver disease. But again, as I said earlier today, non-alcoholic fatty liver disease is everywhere. And so many of our patients are presenting. They may have viral hepatitis, they may have an additional liver disease, but fatty liver is often accompanying it as well. And of course, hepatocellular carcinoma is also something that we have to survey for afterwards, and it'll be interesting we can share our experiences with this. So how do we treat these individuals? Well, we use a variety of immunosuppressive drugs, and of course the backbone is tacrolimus. We do rarely use cyclosporin-based therapies if they have neurologic issues with tacrolimus, but tacrolimus is the background, and we typically may add a second agent. Typically, for us, it's mycophenolate. Occasionally, it's azathioprine. We do use the mTOR inhibitors as well, though they have some issues that we're going to discuss as well. And of course, in the short term, we use corticosteroids. As induction agents, we occasionally use these T-cell depleting agents such as thymoglobulin. We also use interleukin-2 receptor antagonists as well as the co-stimulation blocker here, belatacept, again, much less common in liver transplantation. We're just going to spend a few minutes on the calcineurin inhibitors. Again, they inhibit transcription of interleukin-2, and it's the backbone of most immunosuppressive regimens. Once you complete the first 4 to 6 months of transplantation, we typically now can immunosuppress individuals at much lower trough levels than when I started in transplantation back in the 90s, some 25 to 30 years ago. We run our trough levels low, and we may need to add a second agent as well. Looking at some of the other aspects of this as well, the reason we have to be careful with our calcineurin inhibitors, of course, is because of some of the side effects, including blood pressure as well as renal insufficiency. Tacrolimus also can be associated with diabetes as well. Cyclosporin has this very unique gingival hyperplasia side effect, but again, it's rarely used anymore. But it is something I'm sure some of our more senior hepatologists who practice in transplant have experienced over time. Sirolimus and everolimus, these are therapies that actually we can use also to minimize renal toxicity. They have some side effects, including pulmonary fibrosis and hyperlipemia. And again, you can't give this early on in transplant because of a black box warning with sirolimus with hepatic artery thrombosis. Mycophenolate is a very effective anti-metabolite, much more effective than azathioprine, has some GI side effects, and you cannot use this during pregnancy. And of course, our corticosteroids we use for an induction and for treating with acute cellular rejection. So when we start seeing our patients back post-transplant, and again, we all are seeing many more solid organ transplant patients in follow-up, what are the disease processes that we need to keep in mind? So the number one is to, particularly in our liver transplant patients, is to look for and manage chronic kidney disease. The metabolic syndrome complications are also important, as are cardiovascular diseases. We need to screen appropriately for malignancy, and of course, metabolic bone disease is also an issue, particularly in so many of our patients who are quite frail when they're coming in to their transplantation, particularly if they're a late referral. So what about renal dysfunction? So the strongest predictor for overall mortality after the first year of liver transplant is renal failure that occurs either before or after liver transplantation. And indeed, in our UNOS data, there is almost a 20% rate of chronic kidney disease defined as a GFR less than 30 by 5 years. It is dependent upon, large part upon the immunosuppression. Again, calcineurin inhibitors vasoconstrict the intrarenal vessels, and this leads to reduced GFR, and over time can also lead to a tubulointerstitial fibrosis as well. This also is associated with high blood pressure, diabetes, and which is why we now try and run our tacrolimus levels much lower than, again, what we did several years ago or many years ago when these drugs were first introduced. And again, as I said, we typically try and run our tacrolimus levels by month 6. We're trying to run them 4 to 6 if possible, and then after 1 year even lower. There are lots of immune tolerance protocols going on, and people are trying to withdraw immunosuppression. That's not yet ready for prime time, but it's absolutely true that you can get patients down on much lower levels of calcineurin inhibitors than initially believed, and it's important to do this while still preserving graft function. One of the ways to reduce calcineurin doses is to add additional agents, and we will use mycophenolate preferentially, but then we can also add everolimus or sirolimus to reduce the potential for renal toxicity as well. And this is, here is a nice, very beautiful glomerulus here, and you can see the afferent artery here, and you can see here when a calcineurin inhibitor is given, you get this vasoconstriction here with, again, all of the reductions in GFR that need to be carefully managed over time. Again, the other toxicities with the calcineurin inhibitors, neurotoxicity, and some of the metabolic side effects. So let's talk about metabolic syndrome in liver transplant patients. Again, post-transplant, the prevalence of metabolic syndrome is highest in non-alcoholic steatohepatitis NASH patients, and this is also seen in our cryptogenic cirrhosis patients. This is before transplant as well as after transplant. But again, as I said, metabolic syndrome is prevalent throughout. So post-transplant, we typically have to be cognizant and be able to manage our diabetes. And we heard a wonderful lecture in the previous session about some of our strategies to manage diabetes post-transplant. It's exacerbated because we give steroids, because there's weight gain. Many of our patients have pre-transplant diabetes and hepatitis C. And de novo diabetes post-transplant is actually quite prevalent, 27% at 1 year. And then after that, the prevalence seems to fall some. We treat these individuals in a manner similar to our non-liver transplant patients, lifestyle changes. Minimizing steroids is very, very important. And really, for us now, after transplant, we give an induction dose of transplant, but really, after 4 to 6 weeks, all of our patients, except those who have significant rejection, are off steroids at that time. And this seems to at least mitigate in some way the severity of the diabetes. Liver transplantation resolves diabetes in some patients, but this is not something we see commonly enough, and they need to be managed quite carefully. While not quite prevalent in Pakistan, we're big fans of GLP-1 agonists post-transplant because in addition to managing the diabetes, it really is very beneficial in keeping the weight gain down as well. What about high blood pressure? Again, the calcineurin inhibitors are drivers of this. The goal is to keep the blood pressure less than 130/80. Typically, to counteract the vasoconstriction of the afferent artery, we use calcium channel blockers, and we prefer amlodipine. You can also use others, but particularly diltiazem, verapamil, they all interact with the calcineurin inhibitors due to a CYP3A4 interaction, so you have to stay away from those. We do use ACE inhibitors, ARBs, as well, particularly in diabetes. You have to start these medicines at a low dose because the potassium level will go up in these individuals, but so you start low and you just trend this. Potassium will go up to 5, 5.1, 5.5, and then over time it adjusts down, and you can typically titrate the ACE and ARB, and it serves to protect kidney function as well. And it's this combination of amlodipine and ACEs or ARBs that we typically use in our post-transplant patients as well. You can, if they have edema that's substantial, you can add diuretics. Loop is what I prefer, but thiazide is also certainly an option as well. I try and stay away from these because it tends to raise the GFR to some small degree. What are some of the others? Well, we use alpha blockers. We can use beta blockers as well, particularly carvedilol, but you have to watch. There are some drug interactions you have to be aware of there. What about dyslipidemia? This is something that, again, is often dependent upon your donor liver. And as we like to tell our patients, many of the allergy sensitivities, their susceptibility to drug-induced liver injury is now dependent upon the new liver. So you have to just keep that in mind. So when they do develop dyslipidemia, you definitely need to keep an eye on this and manage this aggressively. There's accelerated coronary artery disease post-transplantation. The highest effects, again, are with cyclosporin as well as the mTOR inhibitors, sirolimus and everolimus, where they can get substantial hyperlipemia. We typically use all of the classes of agents. This can be statins, this can be fibrates. You just have to do the drug-drug interactions. But typically, we are able to find solutions for virtually all of our patients who require management of hyperlipidemia. And it is very important. It's very important to get good control of the lipids post-transplantation, particularly with all the metabolic syndrome disease that we see post-transplantation. So if you look at some of these comorbidities, and this is shown in this graph, this is just the prevalence of a variety of comorbidities post-transplant. What is the number one comorbidity? It's obesity. And so this is something that has vexed us all, but it's something that we try to intervene. Many of these individuals who are transplanted for NAFLD, they come in, they're quite sarcopenic, they feel better, get a new liver, and unfortunately they can trend up to their premorbid weight, and this can be quite a challenge. However, despite these challenges with metabolic syndrome, happily the outcomes, those 5-year survival rates, aren't different between NASH-related cirrhosis and other etiologies. So despite having some of the comorbidities, they seem to stay out of trouble, at least as far as survival goes. One of the solutions that we are exploring, and this was is actually doing liver transplantation and then adding a sleeve gastrectomy to try and keep the weight down. This was a very nice paper that was reported in Hepatology that showed that a sleeve gastrectomy was superior to behavioral modifications, but again, you have to be able to have buy-in from your bariatric surgeons. We typically, our bariatric surgeons are more fond of Roux-en-Y gastric bypass, but certainly a gastric sleeve is something that helps. You do have to be careful because this will affect the ability of certain immunosuppressive drugs to be absorbed. And for instance, mycophenolate is absorbed in the stomach, and cyclosporin is bile salt dependent. So if you are doing Roux-en-Y gastric bypass, you have to know that the absorption is going to be substantially reduced for a variety of anti-rejection medicines, tacrolimus, mycophenolate, and mTORs. So just be very, very careful. But this is something in the U.S. that we're doing now to try and mitigate some of the complications that we see with weight gain. Gout is also problematic. Uric acid excretion is increased by our calcineurin inhibitors. If they're on a thiazide, that's going to exacerbate this. We can prophylax these individuals. I'm a big fan of allopurinol at low dose. And for acute gout flares, you have to be very careful with colchicine. You can use it at low dose. But we typically use bursts of corticosteroids. And again, because of the calcineurin inhibitor, unfortunately, we can't use NSAIDs as we typically do in somebody who doesn't have chronic liver disease. Bone disease is also important. Bone density, 1 year is similar to the bone density at the time of liver transplantation, and there's a substantial fracture rate. And if they have an early compression fracture, then their recovery from transplant can be impaired. Typically, we try to measure a bone mineral density on an annual basis, and again, maintain the vitamin D level at 30 nanograms per milliliters in addition to some calcium. You can also use a bisphosphonate, and really the other classes aren't well studied, but we use them all, particularly in our cholestatic liver disease patients. We should vaccinate our patients typically before transplant. You can use some of the attenuated vaccines. I list them here. Obviously, post-transplant, you try and stay away from any of the live attenuated vaccines. And of course, they're listed here. But the most important one nowadays is the SARS-CoV-2 or the COVID-19 vaccines. And we make sure, although that our patients are offered the vaccine. We do have some patients who aren't too enthusiastic about taking this, but we then try and vaccinate them post-transplant as well. What about dental care? In the perioperative period, this is important because it's an important gingival periodontal disease, an important source of sepsis. And of course, gingival hyperplasia is something that we saw with cyclosporin. We've discussed this several times. Antibiotic prophylaxis. We just followed the AHA guidelines. Used to be we gave antibiotics for all our liver transplant patients, but with a new liver, Kupffer cells work fine, immune system is fine. We just follow the standard American Heart Association guidance documents, and we don't give any special antibiotics. At least at our center, you can't get a transplant if you have ongoing tobacco use, but that's not true everywhere. And obviously, if there's tobacco use, there are going to be higher rates of malignancy, stroke, coronary artery disease, as well as hepatic vascular effects. But do counsel these individuals. In Pakistan, will you transplant somebody who's smoking, offer transplant, or do they have to stop? So you ask them to stop? Encouraged or mandated? Mandated, okay. So at our center, it's Bilal. What about at UCSF? Huh? 6 months stopping, 6 weeks. Yeah, good. Yeah. So anyway, you have to survey them a little bit more carefully. Malignancy, skin cancer, squamous cell cancer is the most common. They can be quite aggressive. with a 35% lifetime risk. So we do an annual dermatology exam after 5 years post-transplant. And if you have a lot of problematic squamous cell cancers, mTOR inhibitors here are very helpful. Many of these squamous cell cancers can melt away with mTORs, or they're at least ameliorated. And obviously, sunscreen, sun exposure, particularly for Caucasians, is very, very important here as well. What about hepatocellular carcinoma? There are no established guidelines to survey for this, but there's about a 10% recurrence risk if you're within Milan UCSF criteria. We have evolved to a CT abdomen and chest every 6 months with AFP, and we tailor that depending on what the explant looks like. So if you, for instance, had vascular invasion upon explant in a major vessel, we would survey you 3 months post-transplant. And if there's a recurrence, typically depends on where the recurrence is, but if it's within the liver, it's a local regional approach. If it's widespread, then it's more a systemic approach. PTLD is something we do see. It's typically Epstein-Barr virus associated. There are some rarer forms, but typically we reduce immunosuppression. And if required, we give rituximab and chemotherapy if the CD20 is actually negative. Colorectal cancer screening is important for those who have primary sclerosing cholangitis with ulcerative colitis. They need an annual colonoscopy. Otherwise, it's standardized colorectal cancer screening. And typically, we do counsel our patients who smoke, but we don't do any particular special upper endoscopies. And the other malignancies aren't really increased in any way. Finally, just to wrap up, pregnancy, wait 1 year post-liver transplant. Mycophenolate is the only anti-rejection medicine that should not be used. There are some complications that are increased post-transplant in solid organ transplant patients, but in general, most of our post-transplant patients have a live birth, and typically the live birth rate's about 70%. We do refer them to a high-risk population or high-risk OB for that particular reason. During pregnancy, there's an increased rate of rejection, and this is due to protein binding of some of the that competes with the calcineurin inhibitors and can reduce them calcineurin trough levels. So to stop here and to conclude, post-transplant immunosuppression is primarily tacrolimus cyclosporin based. Watch for hepatic disease recurrence, particularly hepatic steatosis and the metabolic complications. Treating hepatitis C, if not already treated, is important, but again, you have the tools to do so here. Renal disease is the dominant contributor to mortality post-transplant, but manage all of your metabolic complications, screen appropriately for malignancy, and again, counsel lifestyle modifications if not already done before transplant. I will stop here, and again, thank you so much.
Thank you, Professor Call. It's amazing amount of experience made to look so simple, but we would like to echo your findings, because in our recent study we also saw an incidence of metabolic syndrome of about 60% in 2 to 3 years post living donor liver transplantation. So you need to look at the bigger picture. It isn't just the graft itself that you're looking at. You need to see what the patient's nutrition is and what sort of lifestyle modifications you need to see, and any drug-induced complications.